Ms. Drake. Hi, how are you today?
I'm doing well, thank you.
Good. I'm Lee. I'm going to be your nurse today, taking care of you. How'd you sleep last night?
Very well, thank you.
Okay. And refresh my memory, if you would. What are you in with?
I've had just a little bit of stomach pain up here, so they're doing some tests.
Okay. All right. And how's your pain this morning?
It's very light.
Okay. Have you had anything like nausea, vomiting, diarrhea,
No.
constipation, any
No.
change in your appetite?
Appetite's down a little bit, I think, because it hurts when I eat.
Okay, all right. So I'm just going to take a quick look at you this morning. First thing we're going to do is listen to your heart and lungs. So, listen to the heart. And I'm just going to have you sit up a little bit. Can you do that without hurting yourself?
Yes, that's fine.
Okay, and I'm listening to her lungs. She's complaining of abdomen. Probably want to just check her kidneys. Does that hurt at all?
No.
Okay. You had any discomfort when you go to the bathroom at all?
No.
Okay. Now I'm just going to mash real light. Well, I'm going to listen first. So listen to all 4 quadrants. Now I'm going to mash really light.
Notice she went last to the place I was complaining of.
So any pain when I mash?
No.
Okay. All right. How long have you been here with us?
I just came in yesterday.
Okay. All right. Well, I'm going to do is just come down here and tickle your toes. Always check their pedal pulses, either tibial or pedal pulses. Make sure that they've got circulation in their legs and the capillary refill. Okay. If they've been in bed for a sustained amount of time, check a Holman sign. And that's pretty much what you're going to be doing when you go in. Of course, while I'm sitting here talking with her, I'm noticing her skin. So the skin is warm, pink, and dry. If she were to have an IV, I would also, while talking with her, be glancing at the IV, looking at the site, making sure that it wasn't getting red or hot. If she were to have a catheter in, I would step back and look at the Foley bag, make sure that it was draining, see what the urine looked like that was being drained. If she, say, were in with a respiratory condition and had oxygen on, I would also check and make sure that the oxygen was hooked correctly and that it was on the correct setting. If she had oxygen on, I'd also be checking her nails, her upper nails along with her toenails for blanching, capillary refill. You see how that bedside assessment is a little bit less in depth than the big assessment? Just abbreviate it. Some of those things that's on your list we're wanting you to check because you're new to this. But you're not going to be checking all of those systems all of the time. You're just going to maybe do a brief assessment of them. But, you know, she doesn't have anything wrong. Well, anytime I've got a patient in the hospital, I'm going to listen to the heart, lungs, and stomach. Just kind of the vital things there. But let's say that she was had a stroke. I'm going to do a neuro exam on her. So I might be testing her pupillary reflex, testing her strength in her arms and legs, you know, seeing what she can move, see if she's following commands, make sure that she's oriented. So depending on what their problem is, will give you some guidance as to what you're going to add in your bedside assessment.
And that's something you just do at the start of your shift or
Mhm.
throughout every...
You do the bedside assessment at the start of the shift because you want to get a baseline on where they are at the start of the shift. Okay. Now, if anything changes throughout the day, then you want to be sure to document that. Let's say that
I started having vomiting.
she started having vomiting, so I would go in, I would re-listen to the bowel sounds, see what they've changed, check the urine, check if she's had a bowel movement, check to see if there's anything different in the bowel movement, if there's blood in it, pus in it, diarrhea, you know, hard stool, whatever. Also, we want to check the vomitus. We always have to look at that stuff. You've got to measure it. and then determine, is it green, is it yellow, is there blood in it? Is there something, is there undigested food and she ate 4 hours ago? Things like that we want to know.
Is that something you would do again in the shift before your handoff to the next nurse, or just leave that
No.
to her?
Usually leave that to her. But any change, you want to be sure that you document. So you're going to really focus on that area if there is any change. Let's say that she was out ambulating in the hall and fell and bumped her head. Then you're going to want to do a neuro exam. Okay? Make sure that she's alert and oriented. Make sure that her pupils are reacting. Make sure that she's not, weak on one side. You do the focused exam when something has changed. So in the hospital, your first assessment, your bedside assessment, is just kind of a general, all-over assessment of the important things. I guess that's the best way to put it. Because it's not a complete head-to-toe, because that you only do once a year. But then, when she's hospitalized, you want to do kind of a head-to-toe, but an abbreviated head-to-toe. Because you got to do that on, maybe 7 or 8 other patients that you're in charge of caring for. So. And then if anything changes, you want to go back and reassess.
Is there a full assessment done on admission?
Remember I told you about the admission assessment?
And who does that, or is that?
The admitting nurse. And it depends on what facility, because some facilities have gotten so busy up on the floors that there is an admitting nurse down in the admissions department. And the admitting nurse does all of the admission information. And then it goes upstairs.
Heart and lungs on everybody.
Yep.
Even if they're walking around and they're doing well,
Always listen to the
they're
heart rate.
tested negative, but you still listen to heart and lungs on every